Hi, my name is Manju Kulkarni, and I'm a staff attorney at the National Health Law Program. The National Health Law Program is a private, nonprofit law firm that works to secure health rights for those in need. This is the first in a four-part series of video trainings on the basics of Medi-Cal eligibility developed by NHELP. In this session, I'll be covering the fundamentals of the Medi-Cal program, including the structural and legal framework and the basic eligibility rules. The first question is, what is Medi-Cal? Medi-Cal is California's version of the Medicaid program. Medicaid is very different than Medicare, but the two are often confused by journalists and policymakers. Medicaid is a federal and state program that serves as a national healthcare safety net, providing access to healthcare services to low-income Americans. Medicare is only a federal program. It is offered across the country, but only to seniors and persons with disabilities. There are no income limits for Medicare as there are with Medicaid. Medicaid is only for those individuals and families with low incomes and limited resources. And as I said, California's Medicaid program is called Medi-Cal. Before we move on to the specifics of Medi-Cal, let's spend a few minutes talking about the Medicaid program more broadly. We call it a federal and state cooperative system. What does that mean exactly? It means two basic things. The laws governing the program come from the federal and state governments, and the funding for the program comes from both federal and state sources. Let's look now at the structural framework of the Medicaid administration. At the top is the Department of Health and Human Services, often referred to as HHS. HHS is one of the agencies under the President of the United States. The Secretary of Health and Human Services is a member of the President's Cabinet. The Secretary oversees many programs, including Medicaid and Medicare, the Centers for Disease Control and Prevention, the Institutes of Medicine, and the Institute for Minority Health. Within HHS are the Centers for Medicare and Medicaid Services, an agency which manages the two programs. The abbreviation is CMS. If you worked on Medicaid before 2001, or you have reviewed materials on Medicaid developed before 2001, you will see HCFA, or the Healthcare Financing Administration. This was the name given to the agency that handled Medicare and Medicaid before 2001. The first box in our diagram shows the federal part of the federal and state cooperative system that administers Medicaid. Let's move now to the state portion. There's a requirement in the Medicaid Act, which starts at 42 U.S.C. Section 1396, that a state designate a single state agency to administer the program. The agency must provide methods of administration that assure proper and effective operation of the state Medicaid plan. Additionally, the state agency is responsible for complying with the federal Medicaid requirements. In California, that agency is called the California Department of Healthcare Services. Prior to July 2007, it was called the Department of Health Services. In 2007, the Department of Health Services was divided into the Department of Healthcare Services, which manages Medi-Cal, and the Department of Public Health, which manages several other programs. As CMS is under the Federal Department of Health and Human Services, the State Department of Healthcare Services falls under the Health and Human Services Agency in California. Now, looking down at the other boxes, let's discuss how the program is administered at the local level. California counties are responsible for determining Medi-Cal eligibility. In compliance with federal and state Medicaid and Medi-Cal laws, county administrative offices handle broad eligibility issues, and eligibility workers make individual eligibility decisions for applications in their county. The next two boxes, fee-for-service and managed care, involve the provision of Medi-Cal benefits and services. Nationally, Medicaid is a vendor payment program. This means Medicaid pays individual and institutional providers, usually private entities, to provide health care services to Medicaid beneficiaries. When the payment or reimbursement goes directly from the state to the doctor or the hospital, it is called fee-for-service. In the private insurance model, this is sometimes referred to as indemnity insurance. In Medi-Cal managed care, the state pays a health plan, the middleman, who pays providers. One key difference between fee-for-service and managed care is that payment does not go directly from the state to the provider, but to the managed care plan, who then pays the provider. Another difference is the incentives in managed care are slightly different than those in fee-for-service. A positive incentive is the focus on preventive care. A negative incentive created by managed care is that a primary care provider is often expected to act as a gatekeeper and thus restrict beneficiaries access to needed services. Now let's talk about the legal framework for Medicaid and Medi-Cal programs. At the top of the chart is the U.S. Constitution. The Constitution trumps all other laws, and nothing that happens in the Medicaid program in the way that it is administered can violate the U.S. Constitution. For example, a physician who takes Medicaid patients could not say that he would only see Caucasian patients and not African American patients, because that action would violate the 14th Amendment to the Constitution, which guarantees equal protection to all Americans regardless of race and ethnicity. The legal framework for Medicaid also includes federal laws such as the Medicaid Act, which is known as Title 19 of the Social Security Act, which begins at 42 U.S.C. Section 1396. In addition, civil rights laws such as Title VI of the Civil Rights Act govern how Medicaid functions. Title VI provides federal authority for linguistic access to healthcare services. Those of you who work on language access are likely to be familiar with that provision. In addition to the Medicaid Act or statute, there are Medicaid regulations, which generally begin at 42 CFR or Code of Federal Regulations, Section 431. I want to take a moment to outline briefly the difference between statutes and regulations. Statutes start off as bills and become law after they are passed by Congress or the state legislature and signed by the president or the governor. Federal and state regulations are drafted by individuals who work in federal and state administrative agencies. Federal Medicaid regulations are written and proposed by people who work at HHS and CMS. Regulations provide additional details on how administrative agencies should run and how government programs should be implemented. Advocates need to know and understand regulations as they do statutes because important information about Medicaid is found in the Medicaid regulations. Next in the legal framework for Medicaid is the federal agency guidance. This comes in the form of CMS policy letters known as Dear State Medicaid Director letters or Dear State Health Official letters. These letters provide direction to state Medicaid directors regarding recent changes in the law. There's also the State Medicaid Manual, which provides further detail about how Medicaid programs should be implemented, including what services are covered and which individuals are eligible for services. Now we move on to the state portion of the legal framework. Just as federal law had a Medicaid Act and regulations, in California we have a Medical Assistance Act, which begins at Welfare and Institutions Code Section 14,000, and Medi-Cal regulations that can be found at Title 22 of the California Code of Regulations, Section 50,000. The state statute and regulations provide quite a bit of information about how the state implements the Medi-Cal program. Additionally, there is state policy guidance, which comes in the form of policy letters and manuals. The ones you will see most often are the All-County State Welfare Directors letters. The letters are sent from the State Medi-Cal Eligibility Branch of the Department of Healthcare Services to the welfare directors who manage county administration and handle eligibility. In addition, there are Medi-Cal Managed Care Division letters that are sent to health plans from Medi-Cal Managed Care Branch of the Department of Healthcare Services. These letters explain how managed care plans should provide benefits to Medi-Cal managed care beneficiaries. There are also a number of policy manuals, which include the Medi-Cal Eligibility Procedures Manual, specific provider manuals, and the Manual of Criteria. Most of these can be accessed through the Department of Healthcare Services website, www.medical.ca.gov. I want to point out there are also state laws known collectively as the Knox-Keene Act. The Knox-Keene Act and regulations of the California Department of Managed Health Care provide consumer protections involving the delivery of managed care services. Examples of Knox-Keene protections include rules that require that individuals enrolled in managed care plans have access to their medical records, and that women in managed care plans be able to designate an OB/GYN as their primary care provider. You can find more information about Knox-Keene provisions on the Health Consumer Alliance website at www.healthconsumer.org.